Good morning and welcome to Hamilton Health Sciences Department of Medicine Grand Round. Just a quick recap of our housekeeping. We do have both the chat and the Q&A functions today. So if you need to bring in a conversation, use the chat, but please use the Q&A for questions. Dr. Piesens will take on the questions at the end of her presentation. So today we have Dr. Eva Piesens, who's going to speak to us about Lyme disease update in 2021. I will time the presentation as the season is starting for the outdoors. As we all know, Dr. Piesens is an associate professor of medicine in the Division of Infectious Diseases, and she is the program director for the Infectious Disease Residency Program at McMaster University. She completed her medical residency and residency in infectious diseases from Boston, and have worked in hospitals affiliated to Georgetown University and Tufts University before moving to McMaster in 2012. Dr. Piesens is interested in education, infections in the immunocompromised host, and Lyme disease. So it's no surprise for us today that she's going to update us on what's happening in Lyme disease in 2021. Without further ado, Eva, please take over.
Okay, thank you very much for the opportunity to speak. I chose this topic because the Infectious Disease Society of America came out with new guidelines in 2021. And I wanted to see what had evolved over the last several years. The guidelines are done by both US and Canadian representatives. I have nothing to disclose. The learning objectives, an understanding of Lyme epidemiology and transmission locally, because that really does inform the decision-making around testing and treatment. Assessing the risk of Lyme transmission after a tick bite with appropriate follow-up measures, understanding the common clinical manifestations of Lyme disease, and the use and interpretation of Lyme serology in the context of clinical stage. And then at the end, as you probably know, there's a lot of controversy between public health IDSA guidelines around Lyme and this concept of chronic Lyme. And I'm hoping to define it and show you a couple of studies that argue against chronic antimicrobial therapy. So the story of Lyme really started in 1975 when a mom of three called the Connecticut Public Health Department because 3 of her kids had been diagnosed with rheumatoid arthritis. She knew of several of their children who had been diagnosed with rheumatoid arthritis, and she thought that was very bizarre. And luckily, a rheumatologist, Dr. Alan Steer, was sent to investigate. And in the case definition, he found 39 kids and 12 adults. And many of those had had a rash. And that's sort of what sets the stage for the discovery of Borrelia burgdorferi, which was this to be, and Lyme sort of takes off from us. The northeast of the US, so from New York State, Connecticut up to Maine, is what we call hyperendemic. And so probably about 60% of ticks are infected with Borrelia burgdorferi. There is another pocket in the upper Midwest, and clearly both of those areas abut Canada, and then much smaller areas of Lyme out west and in the south. In Canada, the epidemiology of Lyme has been moving sort of north and west along rivers. So the main risk areas are Southern Ontario, going up to Toronto and Ottawa. There are risk areas in the east, in Halifax, and then smaller risk areas out west. Again, having the tick in the environment does not necessarily mean that that tick is infected, and I'll show you some data, but certainly establishes a risk area. And the risk areas are projected to continue to grow with global warming and tick migration over the next 10 to 20 years. The other thing that I'd like to point out, and I will come back to this point, is that Lyme is really not a North American phenomenon. There are other species of Borrelia called Afzelii and Guerinii that are in Europe and Asia. They have slightly different clinical manifestations, but there's a significant amount of overlap. And a history of possible European exposure changes what kind of testing you're going to ask for. And again, I'll come back to that when we talk about screening. So the first point I'd like to make is epidemiologically, Lyme is really a global disease. This is estimates from 2018, where Canada has about 2.7 cases per 100,000, the US 37 per 100,000, most of which are in the Northeast. And estimates in Europe range from 10 to 100 cases, depending on the tick burden. I would say Eastern Europe is probably the heaviest burden, but I've diagnosed people from Scotland with Lyme disease, for example. Lyme is transmitted, Borrelia is transmitted by the black-legged tick, not the dog tick. And I'll show you some pictures in a minute. And the ticks themselves have a 2-year cycle. So eggs are laid and latch into larvae. The larvae are not infected, but they become infected when they feed on intermediate hosts, such as mice and birds. They will grow to be nymphs. Nymphs tend to feed on people as much as birds and deer. And then they grow into adults and lay eggs again. And that's a 2-year cycle. Ticks are dormant in sub-freezing temperatures, but anytime there's a warmth, they will start to move again, and you have the potential for exposure. Most exposures, most cases of primary Lyme, do show up in the warm months. So May to October, with the highest rate of primary Lyme in June, July, and August, which makes sense in terms of both warmth in the environment and human activity in sort of wilderness and brush. So the first thing is really to understand in Ontario, if you have somebody with a tick bite, what is the risk for Lyme disease currently? And I think this is a fairly common scenario. So this is a mom who calls because she found a tick in her 7-year-old's back at bath time. And her daughter had been in a wooded area for most of the day playing soccer in a field. She's really not sure if the tick was there when she dressed her this morning, but she is sure that it was not when she dressed her this morning. And so what are the questions that you want to think about when you assess for Lyme risk? You know, the first question is it a deer tick? And this is a chart of tick submissions to Niagara, but you'll see that of all of the ticks that were submitted, somewhere between 15 to at most 30% were actually deer ticks. And so if it's a dog tick, it does not transmit Lyme disease. And your sort of question ends there. This is pictures of adult females. Sorry, the red on my left is the adult female tick. The smaller tick next to it is the adult male tick, and then nymphs are below. You'll see that the deer ticks are black-legged as opposed to the wood ticks that have brown legs. And then the spot on the back is black as opposed to variegated. Again, public health will identify a tick for you if you send it in. Many people can distinguish, but not all. The other question is, what if you have a deer tick bite, what is the risk of that tick actually containing Lyme disease? As I said, in hyperendemic areas such as the northeast of the US, up to 60% of ticks are infected with Lyme. In Canada, and this is a representative slide again from Niagara, you'll see that somewhere between 11 to 18, 19% of ticks are actually positive for Lyme disease. Now, obviously, this is a flawed sample. These are ticks that people found on them and sent to public health. But nevertheless, we're not approaching a hyperendemic scenario, although certainly Lyme is present in Ontario. And then the last question is, how long was the tick embedded? So Borrelia lives in the hindgut of the tick. When the tick feeds on a mammal, it ingests blood, and both the temperature and the oxygen content raise in the hindgut, which causes the Borrelia to change from a sort of static phase to an active phase. It then needs to migrate to the foregut in order to penetrate the skin. And that process in mathematical modeling takes at least 24 and most likely more than 48 hours to complete. And so when we look at assessments for prophylaxis, there's really no recommendation for prophylaxis or testing if the tick has been embedded for less than 36 hours. The longer the tick has been embedded and the more engorged the tick is, the higher the risk of transmission of the Borrelia if the tick is infected with Borrelia. So with those considerations, the recommendations for chemoprophylaxis are the tick is an Ixodes scapularis, so it is a black-legged tick. Tick bites occur in a highly endemic area, which is greater than 20% of nymphs are infected. I don't think Southern Ontario is there quite yet, but we have been steadily approaching that. And the tick has been attached for at least 36 hours. There have been a couple of studies of prophylaxis, one looking at doxycycline 200 milligrams as a single dose, or amoxicillin for 10 days, as long as it started within 72 hours of tick removal. And so coming back to our case, this is actually relatively easy. This is a tick, regardless of what type of tick it is, that is a low risk exposure because the tick has only been embedded for 8 to 10 hours. So even if the tick was an Ixodes tick, even if the tick was infected, this child is not going to get Lyme disease from this particular bite, although usually when you have one tick, you may have others. And so you may want to monitor and educate, but you do not need to treat. And as I'll show you, there's really no role for antibody testing at this time. So when do we use antibody testing? And again, the reliability of antibody testing is going to vary with the stage of Lyme, as I'll show you in a minute. This case was a 25-year-old hiker from Long Point who presented with a 7-centimeter oval lesion. She had a vesicular center, so not a classic target lesion. But she and her boyfriend noted that it had been increasing in size steadily in a somewhat circular fashion over the last 3 days. She did not recall a tick bite. And if you look at studies, many people do not recall a tick bite, particularly if it's a nymph. It's often quite small and can fall off before you notice the rash. But her partner had noted that they were deer ticks on their hike. So you think clinically this might be Lyme, but the rash is a bit atypical. Do you wait to treat until you get a positive antibody test? And to take a step back, Lyme is thought to occur in sort of 3 distinct phases. The first is the acute cutaneous or primary phase. And this is in about 85 to 90% of people, an EM rash, a target rash. The early disseminated phase is where the Borrelia leave the skin and migrate through the vasculature. And that can present as multiple rashes. It can present as a flu-like illness, so high fever, chills, malaise, sometimes a little bit of hepatitis. Or some of the other acute manifestations would be Bell's palsy, an aseptic meningitis, or carditis falls into this. And then even without therapy, most people control that infection and either get rid of the Borrelia infection altogether or can present with late manifestations. And that can be anywhere from 3 to 6 to a year later after your exposure. And that can be Lyme arthritis or neurologic disease. And so our case would be considered acute cutaneous disease, particularly if she has no other symptoms. In Ontario, and sorry, this is a complicated slide, but I just wanted to point out that in diagnosis between 2005 and 2014, about 36% of people presented with early localized disease, 20% early disseminated, and then about 40%, 42% with late disseminated disease if you look at the top line. I will say that these proportions have probably moved closer to the early localized, and so we're seeing less late disseminated disease because of earlier diagnosis and earlier pattern recognition. If you go down to the bottom, so if you look underneath hospitalization here, you'll see that 87% of people who were diagnosed with early localized disease had an EM rash. And that is consistent with what's seen in the literature. People may remember an EM rash in hindsight, but they will not have a rash when they present with late disseminated disease. And you'll see people remembering a rash goes down the later it is from the acute exposure. About 60% of people who presented with early localized disease did have some flu-like symptoms. That goes up to 88% in later disease. 86% in late disseminated, I think, is a bit of an overcall based on literature. And then the manifestations that were seen were, again, cardiac, neurologic, or arthritis as the primary late disseminated facet. And so the clinical presentations in Ontario really do match the literature coming out of the US. Just to summarize, because I know the table is very busy, early localized or the rash happens 3 to 30 days after a tick exposure. And it is a single erythema migrans or EM rash in about 80 to 85% of people. Stage 2, as you see, can overlap with stage 1. And so it tends to happen a week to 6 weeks after the tick bite. And that can be multiple EM lesions, what's called early neurologic Lyme disease or Bell's palsy, which can be bilateral or an aseptic meningitis, and then Lyme carditis in about 5%. These are examples of the EM rash. And so the target lesion is, what's described in the literature, that is, and, with the epidemiology, but it can look almost like a spider bite with an allergic reaction. You might see a faint halo there. It can be in an atypical location, such as behind the knee, where it's more of an oval shape. It can blister or actually ulcerate. And on darker skin, the migration, which causes this band here, may be very difficult to look. And so there's clear indications that on African or darker skin, that there's a delayed diagnosis of Lyme disease, and you really need to keep an open mind in the proper epidemiologic exposures. The differential diagnosis of an EM rash is broad, and I include this slide. The most common thing that you're going to want to think about is cellulitis. One of the hallmarks of the EM rash is that it should sort of expand 1 to 3 centimeters daily with the Borrelia migrating through the skin in somewhat of an oval or circular fashion, right? Which is not the way cellulitis will typically present. Spider bites tend to be sort of finite in size. Urticaria tends to be finite in size. And so a classic EM rash is fairly pathognomonic. This is the differential if you're not 100% sure, but the growth over time should really raise a suspicion that it's erythema migrans. Before we talk about the appropriateness of testing per stage, I just wanted to review how testing is done by public health. And I will say, I trained in the States that the public health testing is modeled on the testing that was outlined by the CDC. So it's a 2-tier test. It's an ELISA, which is a screening assay. So more sensitive, but less specific. If the ELISA is positive or equivocal, then a reflexive Western blot is done. And the Western blot includes both an IgM and an IgG. And you'll see, depending on stage, the ELISA is positive, the IgM is positive, it's the right clinical stage, you go ahead and treat. If the IgM is negative, but the IgG is positive, that typically takes about 8 weeks, and it's an indication of sort of older exposure, but you may want to treat in the right clinical setting. The one thing to say, and I'll bring this back at the end as well, is that the ELISA that we do here looks for Borrelia burgdorferi, and it has a shared protein with the European strains. And so it will also capture infection with Borrelia afzelii or Guerinii. There are a couple of minor Borrelia species in North America, Mayani and Miyamoto, where the ELISA will not pick up that infection, but those are really on a case report level and not considered endemic anywhere. If the ELISA is negative, public health will not do a Western blot. And this may be a false negative due to timing, or it may be a true negative, and we need to think about other diagnoses. So 2-tier test. The sensitivity and specificity for early disease, so stage 1 or early stage 2, is only 29 to 40%. So in this instance, Lyme and syphilis really mimic each other. A syphilitic chancre has about a 50-50 chance of having a positive RPR. An EM rash has a 30 to 40% chance of having a positive antibody. As you move through the stages and you have more time for your immune system to react, as I'll show you, the positivity goes up. And so for our hiker, we know that there's Lyme disease in Long Point. We know that she's been around habitats that have deer ticks, and she has, so I would say, a typical variant of the EM rash with the vesicular center. So she does not need antibody. She does not need antibody testing. She needs treatment. Again, an EM rash in the right epidemiologic setting needs treatment, and there's no indication to do an antibody because there's a high rate of false negatives. The role of antibody changes in later disease. And so typical case, a 56-year-old gentleman who presented to my clinic in November with right knee pain, swelling in month, a subacute process. He'd had an arthrocentesis that showed a white count of 18,000. There were no crystals. His cultures were negative, and he was treated empirically with cefazolin without any benefit. He did not recall a tick bite. He did not recall a rash, although he was from Niagara and was a boater, and so spent a significant amount of time outdoors. So late Lyme disease, again, many people will not remember the rash. So you need to think about the diagnosis on clinical grounds. Lyme arthritis is typically monoarticular or oligoarticular. Knees are the most common, ankles, and then sometimes hips. It is very rare to affect elbows and shoulders, and almost unheard of to affect small joints such as hands. Late neurologic Lyme disease, instead of the typical sort of viral meningitis or aseptic meningitis, is more of an encephalopathy. And so you have very mild objective cognitive abnormalities. People complain of brain fog, of being unable to do their usual work. It can sometimes also present as a peripheral neuropathy with a sort of stocking and glove distribution, but it does not tend to affect small motor neurons. This is where the North American and European strains differ a little bit. And so the North American strains, the Borrelia burgdorferi, most commonly will present with Lyme arthritis, rarely with radiculitis, excuse me, and rarely with neuroborreliosis. Whereas European Lyme, particularly if you have a young person with sort of atypical dementia symptoms who have spent time in Europe, it is the most common manifestation is this sort of slow cognitive decline. European Lyme has a couple of specific skin manifestations if you happen to come across them. So Lyme lymphocytoma, that's just an aggregate of lymphocytes where there's some Borrelia, typically on the ears. And then nerve damage. This is actually the hand of a 30-year-old woman who, because of chronic nerve damage, has developed significant skin changes as well. And so those should be indications for Lyme serology. And we see here, if you focus on the bottom, the two-tier testing, we go from 30 to 40% positivity to 30 to 80% positivity in early second Lyme or convalescence from an EM, to 87 to 90, and then to 97% with arthritis. And so the longer you have untreated Lyme disease, the more your immune system recruits antibodies, and the more likely you are to have a positive antibody on testing. If you flip that, the negative predictive value for Lyme arthritis, particularly a subacute process, is actually quite good. A negative antibody makes Lyme arthritis very unlikely. And so for our gentleman, because he had a sort of risk exposure and had really a typical presentation for Lyme arthritis, we did do a Lyme antibody, which was positive. Treated him with doxycycline with, I would say, about 95% resolution of his joint symptoms. I'm not going to dwell on treatment. It's been very well outlined in multiple papers. I will point out that the drug of choice for most presentations, unless there's a specific contraindication, is doxycycline, with amoxicillin and cefuroxime as sort of second-line oral therapy. Doxycycline is recommended for an aseptic meningitis or radiculopathy unless you have sort of systemic concerns and want to do ceftriaxone. It's recommended for Bell's palsy. It's recommended for carditis unless there's a complete heart block. So if somebody is admitted because of Lyme carditis due to concerns about heart block, they should really be on ceftriaxone until you see a clinical improvement. And then the other place that IV therapy is recommended is if you fail doxycycline, particularly if you have refractory or recurrent arthritis, and you think it's infectious and not post-inflammatory. So this brings me to where the controversy really is, which is people who are suffering, who have multiple symptoms, and who believe that they have Lyme disease, even if their antibodies are equivocal or negative. This is a patient who presented to my clinic. She's a 62-year-old lady, was in Ontario her whole life, recalled 2 tick bites, unknown kind of ticks in Niagara 12 years ago, and presented with several months of progressive fatigue, myalgias, cognitive dysfunction, or brain fog. Her public health Lyme tested showed an equivocal EIA or ELISA, and so was reflex to the Western blot. The IgM was positive, but the IgG was negative. And for chronic Lyme or disseminated Lyme, this is actually considered a negative test. The assumption is that your IgG will turn positive within about 8 weeks of symptoms and exposure. And so if you have symptoms lasting for months and a negative IgG, the chronic symptoms are not due to Lyme disease. Like many people, she did not believe this test, and she sent her testing to IGeneX in the United States. IGeneX, for those of you who do not know, is a private lab in California. It touts itself as a Lyme lab. There are several others, including a lab called Armin Labs in Germany. And her testing from IGeneX shows a multitude of positives. So she has a positive CD57. She has an IgM with a single band and an IgG with 3 bands, but a negative ELISA. By CDC criteria, in order to call an antibody positive, you need 2 of 3 bands of an IgM and 5 of 10 of an IgG. And really, there's no data to interpret borderline Western blot with a negative ELISA. And by CDC and public health criteria, again, this is a negative test. I will say 2 things about the Lyme literate testing. One is that at least IGeneX in particular has never allowed any outside look at how they're testing, what are their testing protocols. They've never been validated, and they've never allowed duplication to sort of confirm that they're doing things properly. The other is that they're using interpretive criteria that are not validated. So for example, if you go to Texas, where Lyme is very, very unlikely, about 30% of the population has a positive IgM band for Lyme disease at KD41, and they do not have Lyme disease. And so clearly there's overlap in these antibodies, both genetically and with other illnesses that make it hard to interpret. So she came to me essentially demanding IV therapy, and she believed that she had Lyme disease. Again, and this is a useful table to show patients, she would have fallen under the late neural based on her symptoms with the encephalopathy, but her antibodies, as I'll show you, really are for early Lyme. So persistent IgG does not support a diagnosis of late neurologic disease. The other is, this is a study that sent the blood from 40 medically healthy controls to a university reference lab, a commercial lab, and then 2 specialty labs. And I'll point you to kind of this discordance. You'll see that many tests, there's discordance both ways. So the university lab had a 12% positivity for ELISA. The specialty labs were a lot lower, so potentially missing active disease. And yet when you look at the IgM, the university lab and this commercial lab had significantly more negatives, and the specialty labs, especially this one, 37% were positive using their technology. And so this discordance, this is the same blood in all four places. This discordance really makes you wonder what specialty labs are doing and whether or not you can rely on the testing. Now, I will say that the testing is based on sort of mathematical modeling and sort of antibody testing in hindsight, right? So if you test people with Lyme arthritis, in most studies, there's a 97 to 100% concordance with the antibody testing. But they tested as somebody already has the diagnosis. I'm not sure if that's making sense. And so the one black box is the 2 out of 3 IgMs and the 5 out of 10 IgGs, both sensitive and specific enough to pick up everybody who has Lyme disease. And we don't have an answer to that yet, although there's an ongoing study in centers in Canada, including in Kingston, that is going to look at the chance of actually having Lyme based on the number of Western blot bands that you have. And so that's hopefully data that I can present at a future conference. As I said, many of the specialty labs use unvalidated tests or tests that have frankly been discredited in the literature. So there's no such thing as a Lyme antigen in urine. Lymphocyte transformation tests do not work. CD57 is not specific to Lyme. There's a whole sort of litany of these that you really need to look at with a grain of salt to see if you can interpret them for your patient. So what to think about in this lady? Her ELISA was borderline, was not quite positive, but it was borderline, and she did not have a Western blot that was positive. Think about early disease. So perhaps her clinical symptoms are a red herring and she has new Lyme disease to add to her burden. Think about European Lyme. So if she had been to Europe, this is the pattern, borderline to positive ELISA, but a negative Western blot. This is the pattern that shows up for the European strains of Lyme. And in that case, you need to order the test and ask for a European Lyme Western blot. That gets sent to the national lab, comes back in about 3 to 4 weeks, but will sort of give you a negative or confirm that you have a European strain. And I've had about half a dozen people with chronic neurologic symptoms who had European Lyme and improved, did not resolve, but improved on antibiotic therapy. There are other chronic infections that can give you false positives. So syphilis would be the most common. It's the most genetically related organism. Reports of tularemia, relapsing fever, mononucleosis, HIV, hepatitis C, and hepatitis B. And so in people with chronic symptoms, particularly fatigue and malaise, and an equivocal or false negative Lyme antibody, that's testing that I recommend depending on their epidemiology. There's very clear cross reactions with other inflammatory states such as rheumatoid arthritis, lupus, MS. And again, an IgG Western blot should be positive after 8 weeks of symptoms. And so is this simply a false positive? And there's another explanation for her symptoms. So for her, based on available literature, and I did say there is one study looking at the Western blot bands to see if that recommendation needs to be changed. She does not have Lyme disease and should not get antibiotics and deserves a workup for other causes of her symptoms. So in my practice, I've diagnosed rheumatoid arthritis. I've diagnosed somebody with a stroke. I have diagnosed several people with European Lyme, one person with hepatitis C, but I will say that about, 80% of people with chronic symptoms and a negative Lyme test, I don't get a specific infectious etiology for her symptoms, for their symptoms. The other caveat is that you need to distinguish a little bit between post-Lyme syndrome and chronic Lyme. So if you look at the medical literature, post-Lyme syndrome is more than 6 months of symptoms that interfere with function after you've been diagnosed and treated for Lyme disease. And there's no evidence of reinfection, co-infection, or other comorbid conditions. Co-infection happens in perhaps 10 to 15% of people in the Northeast. And you can have co-infection with Babesia microtii or Anaplasma. So far, according to public health, in the Niagara region, there was one co-infection in the last 5 years with Anaplasma, and they have not made any diagnoses with Babesia. So I think despite what Google might say, co-infections in Ontario right now are quite rare. And it's important to realize that, you know, Lyme can be a debilitating illness. And so subjective symptoms such as fatigue can linger in primary Lyme at 3 months. And 10 to 15% of people still have chronic symptoms at a year. That proportion and duration increases with the later stages. And so people with sort of chronic encephalopathy may not go back to normal, even with appropriate therapy, although they do tend to improve in both their functioning and their subjective symptoms. Chronic Lyme is people with persistent pain, neurocognitive symptoms, and fatigue who do not have any clinical or serologic evidence of previous Lyme. And I've hopefully shown that the clinical patterns of Lyme are actually very well defined. So for, you know, peripheral neuropathy, it's peripheral neuropathy. It's not small motor neuron disease. For arthritis, it's large joints, mono or oligo arthritis. It's not diffuse joint pain. It's not small joints in the hand. And so if the clinical syndrome is not compatible and the antibody is negative, that really questions whether people have Lyme at all. And I think raises the question of should people with chronic symptoms get chronic antibiotics? And so the data for long-term antibiotics is, shouldn't say it's poor, it's actually quite good against it, although they are small studies. So there was a study, two studies looking at 90 days of antibiotics versus standard of care and placebo. This was a US study, so it was a mix of IV ceftriaxone and doxycycline. But there was no difference in the two groups at 6 months. Another study looked at retreatment. So you get your doxycycline, you still feel bad, you get ceftriaxone anywhere from 12 to 24 weeks. And there was no difference in the people who got more antibiotics at the end of a year. Now, again, small studies, perhaps they're small, you know, there's the occasional patient who might benefit from longer, but as a whole, there's really no data to support more than 28 days. The people, and this is opinion, not data-driven, the people who I will extend up to 3 months are the people who've had sort of documented very atypical presentation. So if you have transverse myelitis and your MRI and symptoms are not better at 28 days, you probably deserve a bit more. I had somebody with optic neuritis who, due to Lyme disease, who took about 8 weeks to resolve his clinical symptoms. I have extended therapy in people with chronic neurologic, so the encephalopathy, who have a partial benefit at 28 days to see if they'll continue to have a benefit. Because with Lyme disease, unfortunately, there's no test of cure. There's nothing to monitor that you are being successful in your treatment, except your clinical response. And this is just one of the studies followed out at 50 weeks. You'll see that the black bar is the ceftriaxone followed by clarithromycin and hydroxychloroquine. The middle is ceftriaxone with placebo, and then ceftriaxone redoxycycline. And all three groups were essentially statistically the same. And so there was really no benefit of prolonging the 28 days of ceftriaxone with any other medications. So key points, I would say the incidence of Lyme disease is rising in Ontario. And I think clinicians need to be able to recognize particularly the EM rash and treat clinically, because we know that delay in treatment increases rates of disseminated or tertiary disease. So in Massachusetts and in Northeast, excuse me, where I used to practice, we used to see a high rate of Lyme arthritis. So about 60% of people that we treated with Lyme actually had arthritis. In the early days, as family physicians and other physicians understood what an EM rash was and treated early, the rate of Lyme arthritis is now down to about 10%. And so early recognition and early treatment very clearly prevents later damage. The other thing I hope I've made clear is that you can get Lyme disease globally. There's probably Lyme in Africa, although nobody's looking for it. And so in somebody with an appropriate European history and an atypical arthritis or an atypical cognitive dysfunction, it's worth doing the antibody to make sure that you're not missing something that is potentially treatable. Early Lyme disease is a clinical diagnosis and should be treated. The sensitivity and specificity based on available literature increases with the stage of infection, and the longer you've had your symptoms, the better the negative predictive value of a negative test. And really, there's no data to support the use of unvalidated tests or testing centers, and no data to support long-term multi-drug antibiotic regimens in people with negative tests. So that, I think, is my update.
Thank you so much, Dr. Easons, for this comprehensive update. Please put your questions in the Q&A section if you have any question to raise. Eva, you did touch on the chronicity, or I mean chronic disease, and patients who come in with tests from other labs, and I appreciate that. How do you truly deal with those patients? I mean, we've all seen them in our general medicine and infectious disease practices, and I'm sure they get referred to you when they come demanding the treatment. And how do you convince them that that's not going to happen when they're going to turn around and get the prescription from someone else?
Yeah, I mean, I'm not sure I convince very many people, right? I do sort of talk them through taking a step back and doing a comprehensive infectious disease evaluation, right? And make sure that they've had a sort of more holistic evaluation. So their thyroid is okay, their testosterone is okay, those kinds of things. They're not anemic. I talk about sort of chronic infections and get permission to test for HIV, which I've never diagnosed, but hepatitis C, which I actually have diagnosed in a couple of people. We talk about syphilis, again, depending on what symptom is, but most of it is generalized malaise and brain fog, right, is the biggest complaint. And then I acknowledge that there's a controversy in Google. I know that there's a lot of people who call themselves Lyme literate, and I know that there's people like myself who follow public health and CDC guidelines, and I explain my position. And sometimes people come to you on antibiotics and they're very grateful to be able to stop them because they make people feel lousy. And sometimes they don't believe you and they storm out. But, I sort of feel like I've done my evaluation and due diligence, and I document very carefully why I've chosen not to treat, and what the sort of criteria are. I don't know that you can change people's mind or most people's minds with data, right? If they believe they have Lyme disease and they're suffering, it's very hard for somebody to hear a no, unless you can give them an alternative diagnosis. And sometimes you just can't.
What sometimes intrigues me is the ideas like why chronic Lyme has become this thing among people, and to resolve these unknown symptoms, or these symptoms that are not specific. What's with Lyme makes it so interesting?
It's a tick bite. It's interesting. You can say that our testing is lousy. It's intriguing to me that people believe they have an infection without anything positive to document that infection. But in the 90s, it was sort of chronic candidiasis, right? And then for a while, we had chronic CMV. The reality is, I think it's something like 10 to 12% of, as it was a US study, but 10 to 12% of people had chronic debilitating symptoms and were really searching for a diagnosis. And Lyme is the one that sort of emotionally makes sense to people, I guess. I don't know.
So is this then gonna be replaced by chronic COVID? There is a question from Greg. Yes. I know it's a completely different topic, but Dr. Curnow is asking, what about this chronic COVID now? I mean, we call them the long haulers, the post-COVID syndromes. And do you want to shed some light on this?
I think we're continuing to learn, and I think you have to distinguish people who had COVID, particularly severe COVID, and who have chronic symptoms post-hospitalization but have a negative PCR, right? I mean, that happens in any kind of sepsis. You go to the ICU and you have a long recovery even after the infection is gone. So I think those folks, whether it's severity of illness, whether it's sort of co-inflammatory states, whether it's just horrible physical and mental debilitation from their acute illness, that happens in all sorts of illnesses. That's not a huge surprise. I think what we don't really know what to do are the people who are symptomatic or not, who are persistent shedders, right? What do you do with those folks? So I had a lady in clinic who, she's intermittently positive for COVID. She's still tired. Although she has no respiratory symptoms, her O2 was fine. And I did not know what to do with her. I think that's the honest answer, is I'm not sure I know what to do. I think Dr. Curry, are you raising your hand?
I think I'm bringing Greg in. I'll see if Greg, do you have a comment to say?
Yeah, so I really appreciate your input. So you mentioned 10% of people have this chronic fatigue, feeling unwell. And what's going to happen is that we need people like yourself to help sort out the emotional components versus, what are we missing? And I'm hoping that someone like yourself will become interested in this and give some guidelines about this, because I'm fearful if the problem is an emotional issue that needs to be dealt with and we're looking for something else, we might not be helping the person. So I wonder if you give some insights on the long haulers. It's certainly a real phenomenon, but some people have some emotional issues that need to be dealt with, and we're not doing a great job of that. And then they're going to call themselves long haulers from COVID. So for instance, I have a patient who's very debilitated. She had all the symptoms of COVID, but her antibody testing is negative. 6 months later, and what to do to help her. Have we missed something or not, or is this just an emotional issue? So any insights on how we should be approaching this in the future?
So
this could be another grand round, for long COVID. I think it's maybe worth considering this another topic, unless you have a comment, Eva, you want to add to this?
No, I mean, from I guess two things. One is for the people who are suffering, but I do not think have a Lyme disease. And you maybe can translate this to long COVID. I think they need a multi sort of pronged approach. They need a team, right? They need physio, they need mental health, they may need nutrition. They don't need antibiotics. And so unfortunately, my role as an ID consultant is to say, you don't have an infection. I wish I could help you, but I can't. And I think there should be a multidisciplinary team that we can refer people to. And that's probably the same thing with long COVID, right? That's probably the same thing in people who have post-ICU ongoing problems, that they need a multidisciplinary team to kind of support them back to health. But I don't know specific for long COVID. I don't think we know enough about it, to be honest with you.
To reassure everyone, there is interest in developing a multidisciplinary service here in Hamilton, actually in the region as well, to manage the long COVID patients, and most likely will be based on the model from Yale University that's been published. So I think we should come back with a grand round on this in the future with people who are involved in it. So thank you very much, Greg, for bringing it up. There's a question from Anne related to the data from the Niagara region, whether that applies to Hamilton area, or do we have a Hamilton data?
Yeah, so I apologize. I was unable to get Hamilton specific data, but I did speak to the sort of gentleman who, Dr. Patel, who oversees Lyme testing for Ontario as a whole. And the data in Niagara mimic the data in Ontario. They're a good representation in the sense of, you know, am I going to say this? Borrelia testing in ticks tends to occur in clusters. So you may have a good cluster in Dundas in a wooded area and not so much in Hamilton proper, although it never goes down to completely zero. But the kind of 18 to 20, 21% in submitted ticks, and the lack of co-infections, that's true for the province as a whole, based on Dr. Patel.
Dr. Guzman had put in a couple of comments that also raised his hand. Juan, is there a comment you want to share?
Sure. So can you hear me?
Yes.
Yep, yeah, go ahead.
Oh, perfect. So first of all, thank you, Eva, for that excellent presentation. I think we share some patients because I run the syncope and autonomic disorder clinic, and I see a lot of patients that refer to me with query dysautonomia and Lyme disease, especially from US private labs. Yep. I haven't seen in my practice, in my 10 years plus 5 years of fellowship, a patient with Lyme and dysautonomia. Right. So what I apply the same approach. I try to explain it that from my point of view, from the autonomic and cardiovascular point of view, there is no evidence of structural damage or objective disease, right? So, and try to educate them. But as you said, some patients buy it, some patients don't, and then the whole interaction derail. And the other thing that I want to comment is that there are few naturopathic doctors that actually give treatment without proper testing, right? So, and I have seen that in the GTA in few of these practice, and it's difficult for them to, for the patient to accept that this is not totally real, in the sense that it's not objectively from my point of view, from the autonomic function. So how we deal with those practice? How we, what is your understanding of how the ministry or the CPSO manage those practices? They offer those, you know, bogus treatments.
You know, I think it's a very difficult, and I honestly don't know if the CPSO has oversight over naturalists, right? I do know that the CPSO has investigated physicians when they've been reported for misdiagnosing, mistreating based on guidelines around Lyme disease, and have closed some of those physicians down. I've had people very angry looking at me to kind of replace that physician, and they get very angry when I say no. I don't, again, I agree with Dr. Zam. I don't understand how this became a fixed idea, how people truly believe that you can have a chronic infection with no objective findings whatsoever, and need 18 to 24 months of medications, many of which have no proven Lyme activity. So people end up on chloroquine, or they end up on anti-malarial drugs, or, it doesn't make sense to me. But honestly think you would need a psychiatrist involved to try to understand that. The other thing, if I could say to your point about the autonomic dysfunction, people can have Lyme. So I have a gentleman who very clearly has completely positive antibodies to European Lyme, who has small motor neuron disease. Mm-hmm. And yes, I'm treating him. He has a positive antibody. Now, we don't know, there's really no data for treating positive antibodies in asymptomatic people, but he had some systemic symptoms, and he has these small motor neuron issues. And indeed, his fatigue is better. His small motor neuron issues are worse. And that's, Lyme has very well documented clinical patterns. And if Lyme is sort of causing that clinical pattern, you do get better with antibiotics. But in this case, it's a coexistence of two diagnoses, and he's not understanding that longer antibiotics are not going to improve his hand function, because there's two totally different processes going on. So it's very difficult.
We're ahead, we're over with our time, and this has been a great conversation. Eva, thank you very much for great presentation, great overview, and a great discussion. So really appreciate it, and wish everyone to have a great, good day as well.
Right. Thank you.
Thank you very much.